Thank you so much, everyone, for your responses to the survey. I'll pull that up again at the end so you can have a chance to answer. And without further ado, we'll get started with the talk for the day.
Well, good morning. Good morning. This is Dr. Michael Lewandowski. I'm accompanied today by two wonderful colleagues, Dr. Dennis Patterson next to me here, pain management physician, and Paul Snyder, addictions counselor. And we are here today. Today's topic is cognitive behavioral therapy and pain management. And I have been selected to talk about that because I am a psychologist who uses cognitive behavioral therapy. So my thought here today, as we kind of always do, is we invite you all, and I'm seeing some kind of familiar faces now. It's kind of nice. It's a group of folks that we're getting used to seeing. So hello, everybody. And I think we wanted to maybe start if anybody has any questions from our last talk or any questions or any cases to present. We would be happy to make this personal and interactive. And we have cognitive behavioral therapy kind of available to go when we're ready for that. So with that said, does anybody out there have any thoughts, comments in the past couple of weeks in terms of cases and or just questions you have?
I have a question.
We have a question. Thank you.
So in regards to the webinars, can you guys hear me?
Yeah.
In terms of a PR for let's say I'm ready to have one every 6 hours. For the day supply, I don't want the days, I want it to be like over a 30-day supply. I'm getting kickbacks from the pharmacy saying, you know, that's a 7-day supply. Is that a huge issue or am I writing it wrong?
So you're saying you're trying to write hydrocodone as an as-needed medication every 6 hours.
Correct.
And when your patient's taking the pharmacy the script to the pharmacist is calling you and saying, hey, that's a 7-day supply, not a 30-day supply.
Correct.
So
I don't want my medication in 7 days.
well, let me ask you this. So when you, how many pills are you giving for, that are written on that script? Are you giving like number 30 or are you giving number?
Number 30.
Okay. So you're giving number 30, but you're telling the patient they can take it every 6 hours as needed. But you're saying, hey, this is for severe pain, only take this as needed, and this is a 30-day supply.
Yes.
Okay. So a couple things you can do here. Number one, are you writing that it's a 30-day supply on the script?
Yes.
And they're still calling you and saying that? Okay.
Yes. I've had a couple of pharmacists too.
Yeah, and because they're looking at it and they're saying, well, God, if the patient is going to take one every 6 hours, 30 is only going to last 7 days.
No.
It's not going to last a month. And so I think that's where the issue is here, right? Is that your instructions on the bottle versus how many pills are being given are different. So, I mean, the only ways around it is if you know that patient, because some patients will, take your instructions literal, and and they'll just, that 30, that number 30 that you thought was going to last 30 days now, all of a sudden turns into, a week, and they're calling you for an early refill.
That's my concern.
So what I would recommend is you may want to, and if it's patients you trust and you've been giving them 30 for a long time, I would just change the script to say take one daily as needed.
Okay.
And then that's a 30-day supply. And then you just have a side conversation with the patient like, look, if you need, if there's some days where you take 0 and other days you take, 2, as long as, these 30 pills last you 30 days, you and I are okay. I think then patients can understand that.
Okay.
But I think the pharmacist's concern is that when you write one every 6 hours, patients are going to take one every 6 hours, and that script you gave them is only a 7-day supply, not 30.
Okay. Thank you. Makes sense.
Yeah, you're welcome.
Good question. Any other opiate-related questions or in particular, given the AB 474 took effect a few days ago. Do we have a question there, Troy? Is that no?
Is adjusting to AB 474 going well? Were everybody prepared, or is there kind of been some snafus and still trying to figure it out? Or I think our question is probably what we've seen in our clinic is a lot more phone calls to the clinic from the pharmacy. Is what we've noticed. Is we've had a lot of phone calls like that. Interesting, we've had some calls from the pharmacy where they leave a message but don't say the patient's name or and so we're like, or what pharmacy they're calling from, and we're like, how do we address this? So I'm sure there's some angry patients that are showing up to the pharmacy, having to come back to our clinic on a few instances to get everything straightened out.
Well, and also perhaps maybe the
We have a question in Ely.
Ely, yes, sir.
Okay.
Go ahead, we can hear you.
On the AB 474, if the patient is not giving full consent because of dementia or whatnot, and there's no fiduciary, what is the solution?
I would say, does that person have a power of attorney?
So that's what I'm saying. There's no fiduciary.
No, there is no fiduciary. I would just document that in your record, that you're unable to get consent due to the patient's dementia, and that there is no durable power of attorney, and I just make sure you document that in your notes, and I'm sure you'd be fine.
The law does not disqualify me in that situation. It was not specific.
Correct, and that's why I think if you just document the situation in your notes, I think that would get you, if anybody who reviewed your records would say, hey, this guy did his due diligence, unfortunately this is one of those rare exceptions, and they'd probably give you a pass.
Okay, thank you.
You're very welcome.
Okay.
I'm sorry, it seems like we're having some audio issues today. It sounds like people might have some trouble hearing on the other end. I'll try and adjust our settings here and let me know if it gets any better.
Okay. Well, thank you again. Let me kind of go ahead with our prepared presentation on cognitive behavioral therapy. And again, this is an open format, so if somebody has any questions about today's presentation or anything related to pain management, including the AB 474, we'll certainly entertain more questions as we go through. So, cognitive behavioral therapy, a little background. It is really the centerpiece of what I do as a pain management psychologist in the mental health field. And it's really a psychosocial intervention. And it matches beautifully with, if you consider pain a biopsychosocial experience. So it lends itself very well to the treatment of many different conditions, including pain. And it is it's the most widely used evidence-based practice for helping people who have mental health issues, and in my particular world, pain management. The research is really very good, showing that cognitive behavioral therapy helps, and it helps dealing with challenging, the thinking that people have, the cognitions, the thoughts, beliefs, and attitudes that people have, in addition to behaviors tied to, in my particular case, or this case here, pain, people with persistent pain. It was originally developed, though, to treat depression, and I think it's worked fairly well with that. So I'd love to just present the concept from this talk today of our thinking gets kind of sticky sometimes. We get stuck in the way we think about things. And that's really what I believe I do when I'm utilizing CBT for pain. And I'll go into some more explanations of examples of how that stickiness may look. But essentially, my job is to help people kind of take a perspective on things and get unstuck from a thinking pattern or a behavioral pattern that's not working for them anymore. And the other piece that I'd like to just share with you is that I think early in my career, to be very honest, I probably assigned responsibility and blame to the individual that there's something wrong with them, that they get stuck. And I've recently, I've realized at this point in my career that's useless, is to blame anybody for where they are. They are where they are. My job's to help them get to a place where they want to get to, and hopefully it's a better place. So I just wanted to throw that word stuckness or stickiness as a kind of a metaphor for thinking about the people that you see in chronic pain and how they may be stuck as a result of their thinking. So historical perspective, you'll hear people talk about the 3 waves of cognitive behavioral therapy. In essence, and this is pretty simple, I simplified this. The first wave was kind of the old behavioral therapist days, B.F. Skinner, many years ago, and actually many psychologists before him. But the first CBT, the first wave is behavioral. Then along time came a second wave, which is, I think, is credited to Albert Ellis, who really talked about cognitive distortions, about illogical thinking, and the shift went from behaviors to what's between our ears, our thinking. And interestingly enough, we've probably come to a third wave today, which is as exemplified by the work of DBT specialists and ACT, acceptance commitment therapy, who it was actually developed, believe it or not, here at the University of Nevada by Dr. Stephen Payne, who came to the university, the clinical psych program, the first year I attended the program. So he is credited with the development, one of the developers of ACT, and it has a tremendous utility in helping people with pain. I think it's a very valuable tool to use and a way of thinking. So that's kind of a view from 35,000 feet, looking at cognitive behavioral therapy. So a couple quotes. People are not disturbed by events, but rather the view they take of them. And the other one is, things are neither good or bad, but thinking makes it so. So the other day I posed a question, and I said, if anybody can answer this question, I'll give them a copy of my book that I wrote, Pain. And somebody did. It was during our sleep lecture. So I'm going to I will give a copy of my book to anybody who can figure out who that first quote was from. People are not disturbed by events, but rather the view they take of them. Any guesses out there? Any scholars of historic philosophy? Anybody want to take a shot at that?
If you do, please feel free to unmute yourself or send something in via the chat box.
All right, well, think about that. The second one, I'll give you a little hint. Things are neither good or bad, but thinking makes it so, is more of a literary genius rather than a philosopher. So anybody has a shot at that. Things are neither good or bad, but thinking makes it so. And think about that. I'll give you time throughout the presentation, but don't Google that, please. So the essence of those 2 quotes, the reason I put those 2 quotes up there is really to take a look at how important it is how we interpret things. Events happen, things happen, and it's our interpretation of those events that I think are really valuable to take a look at in terms of its accuracy and in terms of its consequences. So, our cognitions, our thoughts are very important things to take a look at. And in particular, in today's talk, in reference to living with a physical sensation, persistent chronic pain. The number one belief or thought that has been researched to the greatest extent in the field of pain management, the one considered irrational belief, if you will, about living with pain is the phrase catastrophizing. And we've done the most research on that, and it has actually been shown to be very critical for folks that end up with problems with chronic pain. And examples of catastrophizing are what I've got listed there. You can take a look at those, and essentially it's awfulizing the experience. It's making it bigger than it is. That I'll never get any better with this. My future is shot. It's terrible having this pain problem. And I'm certain you've all heard these phrases from people that you've seen who have persistent pain. And essentially, what they're engaging is a cognitive stuckness of catastrophizing. And in my opinion, and in the work of CBT therapists, this would be something that we would address. we take a look at asking how well that's working for someone with these type of thoughts.
I've come to
Please, thank you.
think of pain as, when you think of pain, you just think, I guess we've been stuck on thinking of a number, right?
Yeah.
But you never really break down that number. How does a patient derive that number when you ask them how severe their pain is on a scale of 10? And one of the things that I've come over the years to think is that, pain is a summation of three things. One, it's the pain, like where is it located, how severe it is, how intense it is, plus the emotional part. What does that pain do them emotionally? Does it cause them to catastrophize? Does it cause them to be depressed? Does it cause them anxiety? And then minus whatever you can inhibit, or the descending pain pathway, or that can inhibit some of the pain. You take those first two, add them together, subtract it from the pain that you can subtract or get rid of. That equals their total pain score. And so when you're treating patients' pain, you need to think about trying to treat those three different pathways to get a lower pain score. I don't know if that makes sense.
Well,
to everybody.
and as a physician, I certainly see where you're on the minus end. You want to reduce those pain signals.
Correct.
And that's the role that you play.
Correct.
And I think implied in what your example is that it really does require other members of the team to address the other components.
Correct.
Yeah. So very, very good point. Any thoughts on that? Okay, I wanted to just give a few examples of other beliefs that people can engage in. One that I've seen very important, and this is a copy out of a pain questionnaire I developed for my dissertation, which is it's a fear of re-injury scale. And if you can read this, I hope you can. The concept here is that I'm worried that if I do anything, that I may re-injure myself. I may make my condition worse. So really what I need to do is I need to learn how to avoid things. I need to not do things to make this worse. And so at the core belief is that I will make myself worse if I'm active, if I keep moving, if I engage in life. And so this is just an example of a scale that tries to capture that level of the intensity of that belief. And you can see where this could be problematic for people and contribute to their stuckness, if you will. Another example of another core belief, I call it, maybe entitlement's not the right phrase here, but certainly it's frustration. It's the idea that I don't deserve this. It's not right. I shouldn't have this pain, and I deserve better than this. And people that engage highly endorsing these beliefs are very angry, and they're also very stuck because, of course, this sets the stage for I shouldn't have this. I shouldn't have this pain, and oftentimes it leads to externalizing. And you, Dr. Patterson, need to take it away from me.
Yeah.
I can't have this. I don't deserve this.
Yeah, that's kind of the frustration scale would lead to a patient taking probably more of a passive role, right?
Exactly.
Because
Yeah.
hey, I'm here for you to cure me. I can't cure myself. You need to do it.
Yeah. And in a few slides here, I talk about a medical focus versus a rehab focus. And what you're speaking of there is that, yeah, they're still very much involved in the medical focus, which is it's your job to make me better, rather than my job in a rehab
And I'm going to judge if you're a good physician whether or not you take care of it.
Exactly, yes. And I hope you do a good job, too, so I don't have any pain. And the last example that I wanted to show today is a scale that I've called social disbelief, which is the idea that, I'm not believed. My pain is invisible. I've often referred to this as a credibility index score. How credible do you feel you appear to the world? And people that score high on this belief, this idea, is that, man, I have to show others that I'm hurting because it's invisible. I don't have a neck brace. I may not have a cane or crutches or a wheelchair. So, God, I may feel this need to want to show and prove to people that I hurt. So I'm going to moan a little louder, or I'm going to limp a little more, or just this idea that I'm not believed. And, you can imagine what would that do to someone's presentation? What would that do to someone's interaction with family members or doctors? And again, I come back to the idea that if somebody engages and holds on to this particular belief, this is going to lead to their stuckness. They're going to be hard to move. They're going to be hard to grow and deal with what they have.
I had a patient who suffers from rheumatoid arthritis, and they had a flare of knee pain. And so we decided to do, get them involved in physical therapy and do a cortisone injection. Patient showed up the morning of my cortisone injection in a wheelchair, trying to get from the wheelchair to the table to do the procedure. It took like 20, 30 minutes. It was a real show.
Yeah. And again,
And it wasn't just their knee.
it was everything.
That afternoon, they had an appointment with our physical therapist, showed up with no wheelchair, walked in, acted like nothing ever happened in the morning. My medical assistant saw them and said something like, what is going on here? And the patient said, well, this morning, I wanted to make sure he saw how bad my pain is.
Yeah. So
the patient showed up to put on a show to prove to me that their pain is that bad.
And the danger there may be, the danger may be that their pain behaviors are excessively high, which does what? Decreases their credibility.
Correct.
So it becomes a vicious cycle for folks with pain. And again, I came back to that concept, and it leads to their sense of stuckness. So I read this a number of years ago, and I've always liked it, this idea that in this case, you're talking about somebody who's magnifying their symptoms. And that's kind of what the scale is about.
Looking at, yeah.
But I read that symptom magnification may be more than just trying to prove to you that they hurt. It may actually be a sign of their perceived sense of loss of control. I don't have any control in this. And so this may be my way to do it.
Yeah.
And so it may help us not fall into the trap of blaming them. By looking at it as, wow, the high display of social disbelief may just be a way for them to say, I feel powerless here. I don't know what to do.
Yeah.
Anyway,
Yeah.
and get away from that earlier trap of falling into the blame game, if you will. So, in essence, cognitive behavioral therapy, here's the model in its purest form. You have an event, in this little case here of these pictures, here's a snowstorm with cars jammed up. Okay, events are events. We can't change them. We can't make them happen or not. From that event, we have a thought. We think about this event. We interpret it in some way. And that then, in theory, leads to a feeling. Okay? In the example that we have here that I laid out, she's thinking this, and the circle on the next page, or the next picture, which is feelings. I circled the one there where the guy looks angry. So we have an event, a thought that says, this isn't right, this isn't fair, I shouldn't be in this snowstorm, leads to a feeling of frustration and anger, and then ultimately you have a behavior, and now I'm screaming out the window at the guys that are driving with us. So this is the essential model of cognitive behavioral therapy. And from a pain standpoint, these are the events that we look at, and these are the events that we try to help modify for individuals so they can literally get unstuck from patterns that are not working for them.
I can give you an example of that too. With when we're looking at, for example, alcohol. Somebody drives by a liquor store and they think, "Oh, there's a lot of good buys in that store." So the thought is, there's good buys there. That's a motivating thought. Changes the feelings to excitement. Now they're getting motivated to go into the store. The behavior is they buy booze. Okay? Yeah. Event. You're not going to change the event. You're not going to change the building, the trigger, the whatever it is. You're not going to change that. But the thought, the one thing that you can change is, wow, there's a lot of good buys in that liquor store. Goodbye freedom. Goodbye health. Goodbye license. Goodbye money. Goodbye job. Goodbye relationships. Goodbye blah, blah, blah. My feeling now is, wow, I have a lot to lose by going in that liquor store. From goodbye to goodbye. My behavior is I keep on going, and then I say my gratitude prayer. So it's the perception that goes through the mind that changes the feelings which impact the behavior. And that's where, again, the team approach comes in, because we have time, usually 50-minute or 60 minutes with the person, to work through their thought processes, and then also explain to them what they are going to, what they can expect to happen as they get better, as they start healing. Yeah, you have chronic pain. That's a problem. That sucks. But you know what? we're not looking at the pain number anymore, like we're talking about. We're talking about how you can, how functional you are in your life. And so if you're on a scale of 8 or an 8 on a scale of 1 to 10, how we bring that down to a 3, have you be functional, and then how to work through when you have those flare-ups when it gets to a 4 or 5. So that's more of the team approach with the CBT.
Kind of from a global perspective, I just want to make a point here. If you look at the picture here, the CBT, remember we talked about the first wave, the second wave, and the third wave. I would comment on that and say that the second wave cognitive behavioral therapies would focus on the second part of that, your thoughts, and they would, we were trained to take a look at how logical the thinking is. Is there any illogical reasoning here? And the therapy would be then, in some respects, straighten that thinking out, to come up with different, more sound logic that could then affect the feelings and then change the behavior. Yes, rational emotive behavioral therapy. Just to make an observation, the third wave cognitive behavioral therapists may look at this and say, all right, events are events, we get that. Here's a thought. The thought, staying with pain, it would be something like, I've got to get away from this pain. I can't have it. I need to be fixed and cured. And instead of changing or addressing or kind of confronting the logic or lack of logic of that thinking, a third wave ACT therapist may say, you can have that thought, okay? It's a thought. Trying to get away from that thought, it's going to be useless. Trying to change that, it's going to be useless. Basically, come to terms with that and say, and I can still do what I need to do, leading to the behavior, which is I'm not going to avoid life because I have this thought. So I still engage in life as much as I can. So they kind of shifted the strategy a bit. Instead of saying, trying to help people change their thinking, just accept what your thinking is, as long as you can still do what it is you value and you want to do in your life. And that's a really gross simplification of that. But just as a point, that's how I would distinguish some of the different therapists. And we have CBT therapists that are across all three levels out there today.
You know, another thing that's, they did a study and it showed that we have over 60,000 thoughts that go through our brain every day. And so our brain is made to be active. It's made to be functioning. It's made to have all of these thoughts. The problem sometimes is when we get on that hamster wheel and we keep on going through the catastrophe thinking or getting that 1 or 2 thoughts. That's where the mindfulness and CBT and other kind of theories or methods come into play to help that person get through that thought process and kind of halt that and move it to a more productive thought process.
Mike, I got a question for you.
Yeah.
So when you're addressing a patient or trying to treat them, do you try to distinguish like, hey, this patient would probably benefit from going through first wave treatment, or, oh, I think the third wave would treat them better? Or is it trial and error to see how they respond? Or do you use all 3 treatments?
Great question. You know, in part, what I try to do is add another assessment, if you will, in my mind. Consider the idea of readiness for change, willingness to adopt new ways of thinking. I try to see where they are on that scale, and then that will determine maybe what strategy I use.
Okay.
So if somebody is pretty rigid and they're in the medical focus, no, you're the doctor, you need to fix me. All I need to do is get rid of and not have this. I may treat them and approach them quite differently than if somebody comes in and goes, wow, you know, this isn't working. I really love my doctors. They've done their best. And I need to now learn how to figure out how to cope with this the best I can. That's going to be a different strategy. Yeah, okay. But it's a very, very good question.
So no one form of treatment. You know, it's just like all things in life. You gotta look at the patient and treat them accordingly. You just can't make a square peg fitting a round hole.
Yeah. And maybe that's where the artistry of the practice of medicine and psychology and addictions work comes in. And maybe you get that with experience. I don't know. Yeah. But I think there is a good point. Tailoring treatment to the unique needs of that patient is important. So we need to assess them to figure out where they are on some of these dimensions to tailor it to their unique needs.
Okay.
Any questions out there at this time? If you're on video, please feel free to raise your hand or unmute yourself.
Okay, so interrelated, there's several phases of cognitive behavioral therapy. I don't want to spend a ton of time on this, but one of them, the first phase is really educational. It's helping people realize, in terms of pain in particular, that there's a huge difference between acute and chronic persistent pain, and they're treated differently. Ideally conveying the message that pain is manageable, and shaping some of the words they use. Again, they want to be fixed and cured and get rid of. So I try to help people move from that word to manage, cope, deal with, rather than fix, cure, and eliminate. There's a huge learning process, educational. It's a psychoeducational model. So there's some information that we want to share with them at the very beginning of the work that we do. And we emphasize that it ultimately is a self-management approach. It's what they're going to be able to do to help themselves. The second phase is basically skill acquisition, teaching people how to pace themselves, teaching them how to recognize how their thinking can get sticky, and ask them, how's that working with what they're currently using. Third phase, of course, is the maintenance and relapse prevention, helping them problem solve when they have flare-ups or when they have bad days. So that's essentially the three phases of CBT. Yeah, there we go. Characteristics, it's very problem-oriented. As I mentioned, it's educational. It is collaborative, which means that we need to engage the person in the process. We're not doing something to them as they passively sit there. They have to become engaged. And that's a challenge. I'll share a quick story with everybody. I've actually shared this before, but you can imagine when Dr. Patterson sends a patient to me, the very first meeting we have, as I'm a psychologist, is they're sitting there very defensive, guarded, their arms are folded, their legs are crossed, and they don't really want to be there. And I recognize that. And what I'll try to do is break some of that down, that resistance, by saying that, I'm a pain helper. I tell people that I'm not interested in if their pain's real or not. I say I've never met anybody who doesn't have real pain. And then I try to get into getting them to slowly start agreeing with my statements, which is not hard to do, actually. But when I say, pain affects your lifestyle. Pain can stop you from doing things you like to do. And now I get them to basically start nodding their head, saying, yeah, that's true. And I said, I haven't met a person in pain in the last 3 or 4 years that hasn't had their mood affected. They're irritable, they're cranky, they're frustrated, and their heads are nodding. And then I throw in, and people can be depressed and anxious and fearful and worried. And they're nodding their heads a little more. And I say, pain also is a relationship problem. I said, I've never met anybody whose pain is just their pain. It affects everybody around them. And they're nodding again. And now I'm slowly beginning the process of getting to collaborate and to establish this team effort to begin to help them with their pain. So collaborative nature is very, very important. What other key issues here? These are some of the characteristics. You can read those there. I don't think I have anything else to say about those. So it's respectful, it's supportive, it's compassionate. The second point there is assess motivation and readiness to adopt a self-management approach. That's kind of what you were talking about earlier. Realizing that someone may be very ready to begin to adopt a self-management approach, and that's a different way to deal with somebody who's not at all. And I think my next slide here, no, the one after this, we'll talk about that. In fact, I'll get to medical focus versus a rehab focus. And I'm visual, I like to see things. So on one end of the continuum, you've got somebody who's medically focused, which basically is very appropriate for acute pain. And the focus is others do stuff to me. I'm going to present myself and then I'm done. With time, we need to help that person move across that line to a rehab focus, where persistent chronic pain is the issue, and the focus is now on self-management, and it's what they can do to help themselves. It's not all on me. So the last couple pieces here: behavioral activation, activity pacing, reducing avoidance behavior. a huge part of a lot of cognitive behavioral therapists. You can see that relaxation training. I have also personally found that we used to use a lot of biofeedback assisted relaxation training. Today it's more mindfulness training, but in the early days, the biofeedback was wonderful because a lot of folks that had some resistance to mental health, they didn't want to talk about things, but they could sure relate to a machine that was showing them their tension. And that was very helpful for a lot of our patients.
So this leads me to a question that I, CBT,
Yeah.
as a provider, I'm always like, what is it? And then you hear terms like, relaxation therapy, you hear meditation, you hear mindfulness, so are those forms of CBT or are those techniques?
Yeah, they could be techniques and components of a CBT program. Yeah.
Okay.
It's very educative. It's teaching, and those are some of the skills that we believe they need to know.
So CBT isn't necessarily one, they go there and they go through like a set treatment. CBT is formed to treat where that patient is in their, whether it's their thoughts or their feelings or their behavior. You're looking at different approaches to change all three of those things.
Absolutely, and help them get unstuck again
Through different techniques.
all under the umbrella of cognitive behavioral therapy, which has a lot of different components to
So it's just a big umbrella
to help people. Yeah.
So every psychiatrist or psychologist may have a different approach on how to do CBT.
They may pull different components for what they feel comfortable with. And that I guess ties into my point that early in my career, I found that the biofeedback was a really nice way to deal with the defensive guarded patient who doesn't want to see mental health, doesn't believe in it, but can certainly relate to a machine that's got dials that shows how tense their muscles are.
Yeah.
And it was a process to redirect them, but also to show that they can regulate themselves, that they can help, when they get really caught up in this vicious cycle, that tensing only aggravates their pain.
Yeah.
And it gives them a tool to go, I can break this cycle. So, good question. So, yeah, medical focus. So I invite you to think about the next patient you see and say to yourself, where on this continuum do I think this person would be? Where would they put themselves on that continuum from a medical focus to a rehab, which is another way of looking at this self-management. How much are they willing to kind of look at that? So some of the characteristic classic things as we look at thoughts, the assumption is thoughts cause feelings and behaviors. So you go take a look at sticky thoughts. We don't see people. We're not psychoanalysts, so it's not a several year process. It is very much contained, 8 to 16, 12 to 16 sessions we can address what we need to. The emphasis is on current behavior rather than past behavior when they grow up with their parents. It's a collaboration. We talk about goals. It's very much of an instructional teaching kind of a model. We certainly encourage people. Number 5, I think is a good point. It teaches the benefit of remaining calm and neutral instead of trying to get away from something and, oh my God, I can't handle this. That concern about the upsetness becomes a secondary problem in addition to whatever it is they're doing. So we can reduce that by just having them remain calm and at least neutral. It's based on, facts, not assumptions, kind of rational thinking. It's very structured, directive. Ideally, it's tailored to that person's unique, maladaptive, if you will, patterns of behavior. What else? We assign a lot of homework. We have people kind of test things out when they go home.
Yeah.
So this little chart here, it just talks about the different kind of focuses from a cognitive perspective, the behavioral. You can see that under behavioral, we have things like activity pacing, relaxation training, thank you, versus some of the cognitive strategies, maybe more imagery. We try to role play and help people, how would you handle the next flare up, doing these kinds of things. So in terms of your thought processes. And this slide basically shows there's some good evidence that this works. It's not just wishful thinking. The data shows that empirically it's a proven therapy that actually leads to change in people. This last slide really talks more about the acceptance and commitment therapy. I am finding in my career that what I like to suggest to people is I have two buckets of tools. One is kind of the control-based bucket of pain management tools, which includes all of the things that we have here. Some of the, keeping thought records and looking at activity pacing. Those are, I would call those control-based strategies. And then with the acceptance-based, I consider those, I call that other bucket learning how to coexist with pain. I hesitate to use the word acceptance because I've had too many pain patients say, well, acceptance means giving up, quitting, losing, I have to forego things. And in its true sense, even in ACT therapy, that's not what they mean by acceptance. But that's what I find a lot of people will automatically default to in terms of their thinking. So to reduce some of that, I say, I want to teach you ways to coexist with your pain. And people seem to get that word better, I think. They don't go, oh, I'm losing, or it wins, and I'm at a loss here, or I have to give up. Coexistence means that can I live my life, engage in the activities that I want to do, not avoid a lot of things, and have what I have. My favorite phrase there is, can you get on with the business of living despite having pain? People that endorse that, they're doing really well, and an ACT therapist would be very happy with that, because it's not about getting rid of the pain. It's about coexisting and doing the best they can. So, thank you.
So this is I want to make sure everyone knows that this is a website that the state launched, has some information and resources on AB 474, that has some sample informed consent and medication agreement forms, and just a lot of great information for both prescribers and patients. So that's prescribe365.nv.gov, and it'll actually take you to Department of Public and Behavioral Health website, but if you get there, that's the right one. So just want to make sure everyone knows about that. And then Tyson, I saw your guesses on the quote here. So the first one, Charles Darwin.
Charles Darwin. I'm afraid that's a great guess. It's actually Epictetus, a Greek Stoic philosopher, several centuries ago. So he was, we consider him the first cognitive behavioral therapist. The idea that it's not an event, but it's rather the view that you take of that that's really important.
And then is the second one James William?
William James.
William James. Another great guess. It's actually Shakespeare. It's from Hamlet. Things are either good or bad. I think he makes it so. Yeah, Uncle Bill's in there. So great, good tries, and thank you for not Googling that.
And then we have a question raised here from the folks at Mount Grant Hospital. What's your opinion about the difference in doctors right now? Some slowly tapering dosage, reducing frequency, where others are just doing cold turkey, no more refills, no transition, nothing like that.
I mean, when you take over somebody's medications and you start prescribing to them, I think you have a moral and ethical obligation at that time. And so if they're under your care, and just because a law is passed on January 1st, you shouldn't cut them off cold turkey. I think that is unethical, in my opinion. And I think you have a responsibility to comply with the law and to treat your patient, and therefore you have an open dialogue with your patient to, over time, to get them to, where you're complying with the law and they're at a safer place, if that makes sense.
With opioids, you have physiological dependence, you have psychological dependence, you also have addiction. And so all of these can be created. You can create physiological dependence, you can create addiction, you can create psychological dependence. To create that and then let the person just go, and good luck, try to find your next, what would end up being fixed, is just like Dr. Patterson was saying, it's setting them up for failure. That's where the team approach would come in And that's where the strategies come in too, because you have to look at each individual person. If we're looking at the art form of CBT, well, there's an art form with helping somebody through withdrawal. It's explaining what they're about to, or what they can anticipate happening. It's recognizing how long their body has been impacted by this drug. And not everything is 2 or 4 months. Sometimes people are on these things for decades. And so it takes time to walk into that forest. It's going to take time to walk out, but it's doable. And it's doable in a humanistic way. A lot of times too, it's recognizing that once we get the opioid out of the person's system, then they can actually feel better and away from the pain. Because there's opioid-induced hyperalgesia. There's all kinds of different things that the opioids do to the person's body, and the body gets to recognize or anticipate that chemical going into their body consistently. So we've changed the chemical structure, and then just to let the person go would be, again, setting them up for failure.
In going back to the question too, is I think if you just cut a person off cold turkey because you don't intend to comply with the law or don't have the resources to comply with the law, I bet you if that patient turned you into the medical board, they would see you as negligent for basically not treating that patient.
Yeah, for me, the word is, hopefully we can guard against abandonment.
Yeah.
And to me, an option with abandonment is invitation. Maybe it's a perfect time to invite as many mental health providers or addiction therapists into the team. So that would be my struggle. And thank God I have a PhD and not an MD. I would not want to have the power of writing the script. With that comes a lot of responsibility. But at this point in time, I think the key word is to not end up abandoning people because of this.
Well, and another thing is that opioid receptors don't recognize if the person has received it from oxycodone or heroin. And right now, the heroin that's out in the street is much more potent than it was before, especially when it's being laced with fentanyl, like we were talking about before. And when somebody has fentanyl out in the street in the addiction world, if somebody overdoses, that's not a call to run away. That's not a warning sign. That's an advertisement. Somebody can get that drug, which is a more powerful drug, which is a lot of times cheaper, and get a better high out on the street. So we have to put ourselves into that mindset that if you look at everything breaks down to morphine in the body. And so if you have Oxycontin, for example, that's 2 times more powerful than morphine. But it costs about $1 a milligram out in the street. Heroin costs $10 a baggie and is 4 times more potent than morphine. If you're abandoned, where do you go?
Right.
And it's available. So
yeah, and if you look at piggybacking off what you're saying, if you look at the CDC stats, I think in 2014 there was 30,000 drug overdoses, and I think 2 years later we're at 55. And one of the theories is, and I don't know if they've made the correlation yet, is that physicians stop writing to patients has led to that extra 25,000 overdoses because now they're getting, carfentanil, they're getting heroin, and they don't know, how strong or how potent it is, which leads to them overtaking and dying. And so is that as the increase over the last 2 years, even though because physicians are decreasing prescribing, are our overdoses more because these patients, don't have a prescription what we know they're actually getting.
mm-hmm.
Well, any other questions? Otherwise, thank you all, and I trust that the next several months everybody will be well and healthy, and hopefully all of our patients will be taken care of.
Do you need to throw up your survey again, Troy?
Oh, thanks. Yeah, I'll just put up that survey one more time for everybody to respond who hasn't been able to yet. And then this clinic, we won't be back until February 7th. I think that's 3 weeks because this is January is kind of an odd month with 5 weeks in it. So yeah, we won't be back until February 7th.
What's our topic on February 7th?
Let me check real quick. So if you haven't responded to the survey yet, that would be greatly appreciated if you could get your response in. Thanks.
Hey, we need to put marriage and family counselors up there. Or, I have Dominic over here. Hey, Dominic.
I won't even mention that psychologist isn't on that list either.
What? No psychologist on there either?
So next month, February 7th, we will have a talk on depression and persistent pain.
Well, thank you all for showing up. It's nice to see your faces again, and have a good couple of weeks. Thank you.
Thanks, everyone.
Thank you.